ideally we should do on each patient with OSA. Okay, why? Because based on this study, okay, when you do DICE, when you found that there's complete circumferential collapse at the velum pharynx, and complete apic collapse of the base of tongue, there are cases of non-responders to surgery. Surgery means your UPPP, your pharyngoplasty, or tonsillectomy. Okay, but if you do DICE, the only partial collapse of the velum with big tonsils, there are high chance of responders cure with surgery. Okay, so therefore, DICE helps in deciding surgical options and predicts the outcome. Okay, so there is role in DICE. We should think of doing DICE routinely in cases with OSA to help you in treatment decision and tell the patient what are the options. This is the latest one, something that you have to read that I cannot cover in this lecture, but this has been the talking of you. If you go any conferences, sleep conferences, they are talking about patient phenotyping in OSA. What is patient phenotyping? This is personalizing. What is the cause of OSA? Okay, you personalize the treatment according to the problem of the patient. So by phenotyping, you identify, is the patient is anatomical problem or is it non-anatomical problem? Okay, and by using manipulated CPAP testing, it allows determination of non-anatomical traits. Okay, what does it mean? Anatomical, something that you can identify based on your examination. Redundant mucosa, big tonsils, some anatomical retrognathia, some craniofacial anomalies, or patient has lingual tonsils, big tonsils. So anatomical, right? But non-anatomical, something that you cannot examine. You cannot identify based on physical examination, neither with just regular polysomnogram. Okay, there's something that you have to do. You have to manipulate the CPAP testing for you to get some parameters. Okay, for you to identify non-anatomical traits. This is maybe the reason why some patients cannot tolerate CPAP, because their problem is not collapsible airway, but their problem is due to non-anatomical traits. So what are the non-anatomical traits? Yeah, anatomical traits you understand, yeah? Or the collapsible airway. Non-anatomical traits, you are talking about inadequate upper airway muscular responsiveness. The dilator muscle is not effective. Okay, by right there should be some sensors that stimulate the pharyngeal airway to open, or the patient has reduced arousal threshold. Sikit-sikit dia terbangun, sikit-sikit dia terbangun. Of course, they would get sleepiness. Another one is high loop gain. Yeah, high loop gain is something like a little bit of oxygen desaturation cause a lot of changes, like dilator muscle work too much, okay? So that the patient aroused from sleep. Okay, so this is something that I cannot explain. You have to read for you to understand more. So these phenotypes may not be this patient only one phenotype. It can be redundant. Okay, so you have to. This is why they say personalized treatment based on the phenotypes. So the P4 medicine model: personalized, predictive, preventive, and participatory. This is PPPP, you have to read. So this diagram shows OSA can be anatomical, some narrow collapsible airway, or it can be due to contribution of either of these three, or maybe redundant. Yeah, low arousal threshold, high loop gain, or poor muscle responsiveness. So with someone who have upper airway collapsibility, this is the one that I mentioned. You give CPAP, splint the airway, remove the tonsil, do pharyngoplasty in selected cases. Remember Friedman staging, okay? You want to do mandibular advancement in certain cases, right? Weight loss, position therapy, and so on. But those patients with phenotyping, you found that this upper airway responsiveness, okay, reduce arousal threshold, loop gain. So the patient may need other treatment. This is still ongoing research. For example, patient has what do you call that? Apa ni tadi? Sebab benda baru kan. Upper airway responsiveness. The dilator is not working. It's not effective. So you give some stimulant. Okay, you give stimulation. Okay, there may be some drug therapy that can increase the activity of dilators. Okay, if you are dealing with arousal threshold, you may give some hypnotics so that the patient tak terbangun, senang-senang terbangun. Give some hypnotics. Or if the patient has loop gain therapy, sikit je oksigen kurang dah cause a lot of issues. So the patient may have to sleep with oxygen. So these some things that future phenotyping treatment. Maybe you have some idea about this. Yeah, read up. Okay, you are specialist postgraduate level. So in conclusion, OSA must be recognized, diagnosed, evaluated and treated. Okay, early treatment OSA can be very rewarding for patient, doctors and patient. Early treatment can prevent complications. And remember about this future for OSA treatment, phenotyping. Yeah, for you to treat OSA. Alright, with that, thank you very much. Okay. Kita ada masa soalan ke dah habis dah? Habis dah? Ada masa nak tanya soalan ke nak balik? Prof dah nak balik dah. Jom. Ada soalan ke? Burning question? Inhalational injury? Burning? Ada soalan ke? Phenotype, so, yes.
Prof, just want to ask regarding the AHI, is it applicable for old age? Because I heard that for the neonates and children, even more than one is considered as OSA.
This is why the tajuk is adult OSA. So for children, for neonates, for babies kan, there's no like, they have not come off with a cutoff point what is OSA. Yeah? So it's not applicable for children, for babies. Any other question? Yes.
Do you need to use the new treatment staging?
You can use. You can. You said it's updated treatment staging. What changes? They are the 2A and 2B. That's all.
You use the old one for the
Tak apa. You see, it's still 2. Cuma 2A, 2B, 2A, you can see a lot of uvula but not the tip. The B, you just can see base of uvula but you can see most of the soft palate. Okay. Any other question? So,